The way to improve, to reliably monitor your outcomes is to track them and to have peer-reviewed discussion. Because if you've seen your hospital, what's going on at your hospital is different than what's going on at everybody else's hospital. And so I'd like to spend the next few minutes just telling you why what's out there is not helpful, you know, in the vast majority of circumstances, and will not help you improve the quality of care for your patients. Whereas if you monitor your outcomes at your own institution, I just share a little bit of our experience with doing that. So what we have now is we have common things that are used to assess quality and outcomes, or administrative data, chart review, and the collaborative databases. What's nice about the administrative databases, basically these are large databases containing tens or hundreds of thousands of patients, and so that you can draw, these are the kinds of databases that make those headline conclusions that rectal cancer, as patients are or are not getting radiation, and but they don't really tell you exactly what is responsible for that. So in other words, if you do a study on rectal cancer, commonly the database won't tell you where in the rectum the tumor is. They're usually of quite questionable reliability, and it's very, very hard to draw meaningful conclusions from these databases. So for example, a great example would be in the state of Kentucky, they were told they had a quality problem with their carotid end arterectomies, and basically it turned out that on the discharge data set, if you had a neurologic event on the discharge data set, that was attributed to the surgeon, but that was actually the indication for surgery. So that there's a lot of problems, and Richardson's shown that there's a 68% error rate when you compare chart review to the administrative database. So this is what I'm talking about. These are important studies, but basically if you looked at it, in the United States, only 50 to 65% of stage-appropriate patients with rectal cancer get radiation. So that you can conclude that, well, I give all my stage 2 and 3 patients rectal radiation, so I'm a high-quality surgeon. But actually, it must be those other, stupid doctors out there who don't know what they're doing. But if you look at this, and we've tracked this in the state of Vermont, I don't want to get into this too much, but basically what it turns out is that colorectal surgeons use preoperative radiation, general surgeons use postoperative radiation. And here's the data that I'd like to emphasize, is that it's not true that, it's not always true that these patients are inappropriately not getting radiation. If you look, for example, at the general surgery group at the bottom, this is a small cohort, that of 27 patients with stage 2 and 3 rectal cancer, that the reason 9 of them, or the third that everyone's talking about, didn't get it is because the patient on a medical basis was felt not to be an appropriate candidate for radiation, or the patient chose not to have the radiation. So it's not always true. For example, if you have an 88-year-old woman with stage 2 rectal cancer who lives 400 miles from radiation, it's not true that their doctor is a fool because the patient didn't get radiation. So often these things that appear to be quality problems actually reflect very good care. So what we found when we looked at the state of Vermont and regionally is that actually 100% of patients with stage 2 and 3 rectal cancers were offered or considered for radiation. A third, based on medical judgment and patient preference, didn't receive it. So there was not a quality issue in that regard. Similarly, what about the traditional way of auditing our outcomes is with chart review, is to do a bunch of something, then someone goes back to the chart. But as we've shown in our institution, chart review misses about a third of the complications, and in a study sponsored by the American Society of Colorectal Surgeons, that we found 96% of cases that there was what the surgeon believed happened and what the chart said. So the chart's often an alternative reality to what actually happened. Just moving quickly to the collaborative surgical databases. I do think these are important, and that I think participating, for example, the cardiac surgeons in northern New England, basically they've been able to show that beta blockers, aspirin, are important in heart surgery, and I do think that NESQIP is very important, but it doesn't tell you how necessarily you're doing it at your own institution. There was something I saw in abstract form that if you look at different risk-adjusted databases, that in one your institution may be in the top quarter, and in the other you may in the bottom quarter. Which is it? And what about the issue of colorectal surgery? That NESQIP, for example, if you want to look at mortality, well, is really mortality an appropriate endpoint for anorectal surgery? Are you a high-quality surgeon because you can do a sphincterotomy on a 28-year-old without her dying? I think that that's not really what we would say is quality. So to that end, what we've done and what we've elected to do for a number of years now is we use a system called the Surgical Activity Tracking System, in which we have a specially trained nurse practitioner who is just our regular nurse practitioner who rounds with the residents daily and enters complications prospectively. And the key for us is peer review, that twice monthly we meet, we discuss all of our complications, because you know everyone likes to talk about the airline industry, but they don't do administrative databases and determine why the plane crashed. They get the flight data recorder. They say, let's sit down and find out what actually happened in this particular case, and why did we have this outcome, and what process can we change? So that we often use the airline industry, but that's not what they do. They do get the flight data recorder and they figure out what went wrong. So that, as a further example, our data has basically shown us, and I'll go through this quickly, that if you looked at me, you would think, and trust me that I am not, the best laparoscopic colon surgeon at my institution. I'm the old guy, and I do a lot of the open cases, but I do the cases I do laparoscopically are easy. And basically what we saw is in our institution is the complication rate was relatively similar for laparoscopic surgery, but that's because the young fellowship trained guys who are real good do the tough cases. So that what we showed is that the morbidity of doing a laparoscopic assisted cecectomy for a cecal polyp is not the same as doing a laparoscopic assisted sigmoid resection for complicated diverticulitis. So the point is, I guess that, well, we'll skip this one, but I would just conclude by saying that really we should say that no complication and no death is acceptable. And what difference does it really make whether you're a little better or a little worse? The bottom line is that we can all improve. And so I think the key to that is at your own institution, prospective data entry, because your problems are your problems. They're not the same as everybody. There is no national problem. There's a problem that's specific at your place that you need to define clinically meaningful endpoints. I don't know about you, but I'm not really contented that I can tell my patient I'm an excellent rectal cancer surgeon because I shaved the patient within 1 hour of the incision. I'm not sure that's the most important endpoint. And to that end, we need peer review, and that I don't think most of the efforts that are out there are actually going to improve quality. I think they have ulterior motives, and that we need to stop Dilbertizing quality, and it should be something that comes from us instead of comes at us. Thank you.